And I'll start with a non-medical introduction to this topic. A few years ago, Target stores came out with a series of focus advertisements focused on a group of young women who were about to be pregnant, or maybe were pregnant, and maybe didn't even know they were pregnant. And they did this without any knowledge of protected health information at all. They used artificial neural networks to look at the buying patterns of women, young women, who bought baby clothes and things that are used with a new baby in a nursery. And then they went backward in time and saw that this same group of women had certain patterns of things that they shopped for and shopped online, or they bought in the stores. And from this, using artificial neural networks, they were able to predict who was going to be pregnant and have a baby. Again, with no medical knowledge. And it was a very successful advertising campaign. So that's kind of the atmosphere that we're working in, and you can question sometimes the ethics of doing things like this. But that's a non-medical introduction to what I'm going to talk about today. There's an error. I should have said medicine grand rounds. I had Weisweiler Cancer Center grand rounds. Personally, I wouldn't use the word artificial intelligence. I think it should be machine learning rather than artificial intelligence. We don't even know what intelligence is. We don't even know what consciousness is. We don't know how thoughts are created in our brains. So how can we call a machine intelligent? I think the term machine learning is a little more accurate and less of a straw man to shoot down. Well, the reason why I think it's worth discussing at this time, it's becoming a very useful new paradigm in medicine. What we've been using for the past few years is evidence-based medicine. Evidence-based medicine has its uses, and it's definitely got us out of the time where someone would say, well, I don't know, let's try this, maybe it'll work, to the whole paradigm of doing randomized clinical trials, carefully conducted, and then leading to guidelines that are set up by consensus with experts. But there are problems with this. Clinical trials are expensive. They take a long time to do. They're often on a very select, special group of patients that don't really reflect what our patient population might be, for example. And the guidelines are based on different groups. One group of physicians will have their own guidelines and sometimes contradict what other groups have done. And certainly there's been revolution in electronic health records, but they really, at least in their present state, are more for managing a hospital and maximizing revenues rather than helping the clinicians care for patients. And it often adds the burden to the healthcare providers. Think how many hours you have to spend putting in clinical notes after you see patients. Well, machine learning is a different approach. It's data-driven, and the goal of machine learning is to use this data analysis to make better predictions and classifications and decisions, at least to mimic what a human can do, but often much faster and much more accurately. And they generally are based on data that we already have, so you don't have to go out and run a new clinical trial to generate ideas and hypotheses. You can use data that's already in existence. And the thing is, machines are becoming very good at finding complex relationships in data that are way beyond our capabilities to do. And in some ways, they're less susceptible to bias. They don't depend on a select population in a select institution by a select group of investigators, but you can take real-world data and come up with these things. So I want to talk a little bit about what machine learning is and some of these terms that you hear all the time, and just highlight a few examples in medicine. There are actually hundreds, if not thousands, of applications published every day now. And give you a little idea of how they actually work. I'll try to minimize the math and the computer science geeky stuff, but I'll have to show you a little bit. And then why they're becoming popular and some of the pros and cons in using them. Last week in the Cancer Center Grand Rounds, Dr. Gupta, one of our fellows, presented a talk on addressing the issue of cancer with unknown primaries. I mean, this is a serious problem in patients, no matter where you find a cancer, perhaps in the brain or liver or somewhere else. Did it come from that organ or did it come from somewhere else? And that determines how best to treat that disease. So it's a serious problem, and it's even more difficult when you're looking at something we're commonly or starting to use now, and that's liquid biopsies, where you just take a blood sample and look at potential markers in the blood that says this person has a cancer, but where does it come from? So this is results from a very nice recent study where they took the genome analysis from the blood samples of a bunch of people with and without cancer and with different cancers, and also combined them with some protein markers and fed them into a neural network and taught the machines then to predict where the tumor came from in new samples. And you can see the results that they're fairly good. I mean, this is a tough problem, and this is one of the best attempts that have been done so far. So this is like the major 7 types of tumor that commonly you will see. So that's almost a breakthrough, at least in the liquid biopsy field, to be able to take these things and then blindly give them to a machine, and the machine predict fairly well where the primary came from. Well, just to give you a brief history of intelligent machines, they're not new. They go all the way back to Homer's Iliad, around 250, 300 BC. His stories envisioned golden women made totally out of gold, but they were machines and they were intelligent, and they would anticipate all of the needs of their gods, their masters. And also Homer mentioned self-steering ships, where you just tell the ship where you want to go and it would sail off in the right direction. In the 40s, after World War II, there was a lot of work done on primitive computers and the whole idea of machine processing. And Alan Turing defined an intelligent machine as something that if you were communicating to it behind a barrier so you couldn't see it was a machine or a human, you would think it was a human. Well, I think we've already passed that goal because machines can do this quite well. I mean, even Siri on your iPhone sometimes does a pretty good job. Sometimes does a ridiculous job. But that's where it started. And then in the 60s, there was a lot of research as computers got a little better. But probably the thing that really kicked the whole idea of artificial intelligence, at least to my mind, was a movie. You're all too young to have seen it. It was in 1968, a movie called 2001: A Space Odyssey. And the main character in this movie was an intelligent computer, Hal. And they were on a space mission with a bunch of astronauts and Hal was very likable and very smart. And he decided that humans weren't capable of conducting this mission as he was. And so he started to get rid of the humans. After they disabled him, the story became a lot less interesting. But that was when the idea, I think, first hit the popular mind. And then in the 70s, things, they kind of hit an artificial intelligence winter because some folks at MIT proved that with the current models that we're using, you could only solve very limited, uninteresting problems, and the field kind of died until the 80s, and some psychologists came up. They revived the field, and they modified the kinds of learning machines that we were working with, and they also came up with a new way of training them, teaching them to get the right answers, and that revived it. And through the 80s and 90s, then there was a lot of progress made, but it was only incremental. There weren't any big breakthroughs. But around 2006, the idea of deep learning, you'll hear that a lot now, deep learning, neural networks, or the latest version is convolutional neural networks. And this really was an amazing breakthrough that just took the capability of the machines to several magnitudes better. And so now there's so many, it's starting to be applications in every field, including medicine. JAMA now this month is starting a new journal dedicated to machine learning in medicine. Nature and some of the other journals already do something like that. Well, what is machine learning? And what do all these terms mean that you'll hear? You'll hear artificial intelligence, which I think is an impossible goal, but I would say if we call them machine learning, it would be okay. Machine learning typically is two kinds of things: the neural networks, which I'll describe, and then these classification and regression trees. And that's mostly what was done in the early 2000s. That's how Target did its predictions of which group of women were going to buy baby clothes through these tree search algorithms. But this is where the hottest thing now. There's some other methods too, but these are the big two. When you teach a machine, or when you have a machine and it learns, it's done either in a supervised fashion where here's the data and here's the answer, and you just keep giving it examples of the input data and what the output should be, and it learns from that. That's called supervised learning. But there are actually machines that you give them the data and they figure out how to learn themselves, to organize themselves internally to find patterns. But the goal is to generalize from the data that you give them to train with to new situations that hasn't been seen by the machine yet. Well, I'll talk about the two kinds of the most popular kinds of machine learning tools. The first one is CART, which stands for Classification and Regression Tree. And then the latest version of it is called Random Forests. All of this is based on trees and limbs and so forth. But then the artificial neural network is really set up to simulate how our brains work with the connections of neurons that we have. Well, just to set the groundwork, when you train a computer for a given task, you start off with a set of data, and this is where you need the human experts to come up with this data. And this might be 10,000 examples of people who have heart disease. And we want to train a machine to maybe classify that into subgroups. Well, before you do your training, take random subset of that, and that's called your training set. And everything that's left, they just call it bagging because you just put it in a bag, and that's the validation. So the training mechanism ignores this part totally and takes the random subset for training and does whatever it can do to train. And when it thinks it's through, it says, okay, this is the best I can do. Then you compare it. Lost my place here. You compare it to, you apply it to this validation data set. So the machine has never seen this, and this had nothing to do with the training. So it's like an independent verification. And if it's successful, then you maybe put the thing into production or for further testing, or you'll somehow modify your models and start over and do it again. Well, how do these classification trees work? It's really simple. You have some outcome. Perhaps the outcome is death, or the outcome is high risk of death, or the outcome is they have lung cancer versus they don't have lung cancer. You take your data and take each of the individual predictors in regression as to be your independent variables. These are the things that help you predict what the outcome would be. And you take them one at a time and pick the best one that kind of separates your data into the high risk versus the low group. And then you go on down the tree and subdivide those. And here's an example. This is actually a real example of someone with, I think, heart failure, and they were looking at predicting which ones are most likely to die. And they started off here at the top. This is all the patients. There were like nearly 2,000 of them. And using the Glasgow coma score, that turned out to be the best way to predict who's likely to die and who's not. And if the score was less than 5, then there was very high likelihood to die. Whereas if it's greater than 5, then you can further split this into looking at the type of therapy, inotropic therapy that they get and or didn't get. And within those subgroups, you can subdivide patients then by age, and you do it over in both branches of the tree. And then finally looking at some of your clinical outcomes like oxygen gradients and if they had chronic organ insufficiency and what's their mean arterial pressure. You can come down to these final layers, and this predicts fairly well. So that's a very simple idea. You just take your predictors and find which one's best, and then out of that, which one's the best, and out of that, which one is the best. And it works fairly well, but a simple tree like this, if you had 50 predictor variables, well, you'd have this big, awful mess that would take out 20, 30 pages of printout to just print it. And if you wanted to make a decision for a given patient, you had to follow by hand all of that stuff. Well, somebody got the idea of doing a whole bunch of these. And you can specify in advance, well, I don't want 20, 30, 40 different discriminant variables. I want to just do maybe 5 or 10. And doing random sampling and coming up with a set of trees. So it doesn't do just one, it might be a dozen or 20 trees all using the same variables, and they're grown to predict by themselves. And then when the process of tree selection is finished, it takes a consensus. It says, okay, for this patient, run it through the algorithm. What do all of these predict? And it takes a consensus prediction. So it gets much more complicated, but on the other hand, it learns very quickly. Problem is, it's a consensus of computer models that takes a vote on what the outcomes should be. For a human, it's difficult then to predict that, so what you have to do is rely on the machine. You give it a new patient, and it'll go through and find the consensus values and tell you what it found. Well, artificial neural networks, on the other hand, they're designed to mimic how the brain works. And our brain has like 100 billion greatly interconnected neurons. Well, a machine can't even approach that. But The neural networks used today can have thousands of neurons, highly interconnected. And the idea is you have this network, you give an input to the whole network, or in other words, your brain has sensory information coming in, and then it goes through all of the processes and makes a decision or a classification or something. It's kind of like ordinary regression when you have a few predictor variables, x1, x2, so forth, and you want to predict the output. Except there are a lot more predictors. Well, the problem is, the reason why you can't use ordinary regression for something like this, we don't know what that equation should be. Should it be a nonlinear thing? Should it have 50 terms in it? Should it have squares and sines and square roots and all kinds of stuff, or should it be simple? We don't know. So the whole neural network algorithm figures out essentially what the formula should be. And I'll work through this. So here's a typical example. A medical situation where you have these inputs, the symptoms, maybe for chest pain, palpitations, cough, some blood and urine parameters that you measure, and other things like age and gender and whether they smoke or not. And then you put that information into this black box, and you want it to predict, well, are they positive for whatever disease you're looking at, or negative, or can't tell. So that's the fundamental idea of how you use a neural network. It's just a black box. A neuron, the idea of neurons is based on a biological neuron, where you have a nerve cell and you've got all of these dendrites bringing signals in from other neurons or from the outside world, and then it processes it internally and decides whether it's going to respond to that or not, and sends a signal out through axons to other connecting neurons. Well, the artificial neuron does the same sort of thing, except it's not pulse density modulation like an actual neural cell is, but the inputs are just numbers, and the strength of the connection is defined by these things called weights, and then inside this neuron it calculates an output based on those input weights and connections. And this is kind of the heart then of a neural network. And inside, it makes these calculations and calculates an output. The calculations it makes are fairly simple. Inside each little artificial neuron, it adds up all of the input measurements, the x's, and multiplies them by their weights into that neuron, and adds them up, then weighted some. And then there's this little sigmoid type function called a logistic function that calculates the output. So like this would be turned completely off, down here at 0, or this would be completely on, but it's a highly nonlinear function, so we can get some things in between. And that's what a artificial neuron does. So to make a network, you just get a lot of these things and stack them up. And this is called the input layer. So all of the inputs coming in through this. And then you can have a hidden layer. It's called hidden because you don't see them. All you do, present this to the neural network input, and you get the results out, and you don't really see what's going on inside here. And there can be one hidden layer, or there could be 1,000 hidden layers. Right? And I show here with six neurons, artificial neurons in that layer, but there could be literally hundreds or thousands. So you can see they're very huge. And the idea is you want to determine all of these weights that match your output predictions to the input. Well, you can see that gets to be massive computing in a hurry. in the early days when I did a little bit of this, we had to use a supercomputer, one of the fastest computers around at the time, and it would take weeks to train just a simple neural network. And everything about neural networks, everything is a number. All your inputs are number, and it doesn't matter whether you're talking about a picture, images, pixels from an image, or measurement in blood or serum, or urine or whatever. If you were looking at text, it could maybe the word count of different words. It's always a number, and same way with the output, it's a number. It's a 0 or 1, this condition is present or not, or it could be 1 through 10, one of 10 different possibilities output. So that's what's inside this black box. When you give it your symptoms, your biochemical analysis, and what the output should be. Just a couple of more things on how you actually learn, and then we'll be through with all of this computer science nitty-gritty stuff. So you can see the applications would be endless. If you've got a lot of patients that you've been gathering information on over the years, and you know what the final diagnosis is, that's just tailor-made for putting it into a neural network. This could be all the things you measured on those people and what the outcomes were. And so you could set up a neural network then to look at this and find patterns as data and better predict outcomes in future patients. So here's a very crude example, not realistic, but say we had 4 symptoms. Cough, pain, palpitations, sweating, and the output is whether they had an MI or not. 0 means no, and 1 means yes. And these are numbers. Yes or no, they had 0, 1, did they have cough? 0, 1, did they have pain, and so forth. So how do you train the network? Well, and it doesn't sound like it would work, but it does. The first thing you do is you randomly assign some weight to every one of these lines here. So I put just a few. Really, you do it for all of them. It took too long to put them all in. These are just random numbers. And that's the way you start your neural network training. Then you get your data. This is the first patient number 1. And he didn't have cough, he did have pain, he did have palpitations, and he didn't have sweating. And he didn't have an MI. Well, if we run these numbers through our network in a feed-forward method, we know all of these, the weights of all of these, and we can predict then, in this case, the output is like 0.93 for the fact of the inputs that we know and the weights we know. Well, and that's not the right answer. We wanted it to be my fingers are too big for these things. So we wanted the answer to be 0, but it really predicted 0.93, so it was like almost on, but not quite. Well, you can compute the error, then you subtract this number from the real number, the anticipated number, and that's your error, and you square it. And as we add more patients to it, we'll keep track of the total error. So here's another example where all of the symptoms are there, and this should have been an MI, because we knew that's what happened to this person. But our network is not trained very well yet, and it predicts almost no MI, a very low number. So again, calculate the error, add it to your running total of errors, and you do this over and over. many times. And then once you've presented all of the patients to the neural network and you've got your total error, you use calculus. And we're not going to show the calculus to go back and modify all of those weights as a function of your error to try to minimize the error. If we just had two weights, for example, this would be weight 1 and this weight 2, and this is our error function. And maybe when we first started, we were right up here, but we modified the weights over and over and over and over until finally you might reach this place that gives you down here the minimum error term. So that's what you want to do, is adjust all of these weights till your error, prediction error, is as close to 0 as you can get it. And so that's the neural network. It's the end of the math part. And once they're trained, they're very fast. It may take weeks or days or months to train one, but then once it's trained, you can get new data and put in, and it'll instantly give you a prediction. And you can do them on a lot of different devices, computers, your smartphones. They even make hardware chips that you can buy that implement a neural network. And the really good feature is that once a network is trained for a given application, it can be used as a starting point for another application. Google done a lot of work in this field. They have a set of images, of over 1 million different images of common things in the world. Animals, fruits, people, rocks, trucks, cars, whatever you can think of. They've taken thousands of pictures of each object, and they've classified them, and now they've trained neural networks to automatically find the important features in those images and classify what they are. And it works very well. I mean, they've spent years on this, but now that it's done, if you wanted a new neural network that maybe is going to look at lesions on an X-ray, for example, or maybe a nodule on a mammogram, then you can start with this already trained network, and it's not exactly what you want to need, but it's a good starting place, and then you can fine-tune it for your application, and it saves lots and lots of time, and that's a big breakthrough. They do take training data, which means the humans have to set them up. Training time can take a while, and you don't know in advance how many hidden layers you need. There's a math theorem that says you only need one hidden layer to solve any kind of problem like this, but it doesn't tell you at all how many artificial neurons you need in that layer. A good example of, you don't know what the artificial neural networks are doing. When they finally come up with a great classification algorithm, it's all built into this little black box stuff, and you can't look at it easily and tell what it's doing, what's an important feature. I call that the banana problem. I saw a demonstration of a very successful neural network, and they applied it to classifying fruits. So, for example, a banana. If you give it an image of banana, and it would tell you immediately that's a banana. If we were to classify fruits, we'd probably start with a banana. We'd say color is yellow, and then add other features that we can see. Neural network didn't do that. Somebody said, well, what if you gave it a blue banana? And so they gave it a picture of a blue banana, and it's still instantly called it a banana. So what the neural network is doing in its recognition process has nothing to do with what we would do. So that is one drawback to them. But if you're only interested in the classification and not how it works, then that's enough. Well, so why go to all this trouble? I mean, some images should be really easy to recognize. What's the big deal that a machine can do it? Well, almost any toddler can tell the difference between a dog and a cat. I mean, as soon as they can walk around and talk, they'll say cat or a dog or whatever. And they learn that very quickly. Google spent 5 years with lots and lots of experts from Stanford and their own staff, and they also had like 16,000 networked computers and everything else. Finally, after that period of time, they can correctly identify dogs and cats, and then since that time they've gotten even better. Now they can classify things automatically into 5,000 different species. Just to train the dogs and cats, it took 20,000 images with the answers for dogs and cats. Essentially what they do, the neural network, you give it a picture of something, and internally it knows how to look for features that it can use in classification, and then the neural network puts out the classification. But this part, what features are used, is a mystery to us. And now you can download for free the same software and put it on your desktop computer, and it's 93% accurate of classifying animals. You can see how hard a problem this is, because if you look at a picture, they're not clean pictures. This dog, a good part of his lower body is covered up by that bar. This cat's surrounded by a lot of clutter. So, and dogs, pictures may be that the dog's facing the other direction. Maybe you're looking at the back end rather than the face. But somehow these algorithms overcome all of that and can do it. So that's a big deal. Well, let's get back to more medically related problems. This just happened this year. The protein folding problem is one of the big, almost yet unsolved problems in biology. Given that you know the sequence of peptides in a protein, how do you know what the three-dimensional structure of that protein is going to be? And the three-dimensional structure is everything to whether that protein is going to do its job or not. And sometimes just switching a couple of peptides in a long sequence would totally inactivate a protein. Well, if the protein came from a gene mutation, then that protein is not going to work. So that's a big issue. And now there are companies that can build proteins, custom build proteins for you, but you still need to know what the three-dimensional structure is. This is considered, mathematicians can classify problems into different levels of hardness, and the protein folding problem is among the hardest class of problems to solve. But they're getting closer. The same group in Google that learned how to recognize cats and dogs, just this year, there was a worldwide competition to predict protein structures. And what they did, they sent out to everybody who participated 43 proteins. And they didn't tell you anything about the structure, just the sequence of amino acids. And Google, with its deep mind, actually the program's called AlphaFold, correctly predicted 25 out of 43. Well, that's only half of them, but that is a major breakthrough because the nearest competitor only got 3, and that's been the state of the art for many years. So it's like within the last year, there's just major, giant steps made in problems like this. This is a non-medical example, but Google also came up with a program, an algorithm called AlphaZero, that can now consistently beat world-class experts at chess and Go and shogi, which is a Japanese, more complicated version of chess. And they did it by the algorithm actually learned to compete with itself. So it kind of got some of the basic rules in mind, and then it started generating its own test data and its own outcomes. And so it would play itself for millions and millions of times and always refining its methodology. And now it can beat the best experts at all three of these games. Well, in 2006, they came up with a new version of neural networks called convolutional neural networks. And it would take me a month of explaining to see how this works. But basically, in a typical neural network, with the first few layers are the same as what I've showed you. And same way with the output layers. But right in the middle, they have this thing called a convolutional layer. And essentially what it does, it filters out noise and various characteristics. And you can have 20, 30 of these layers if you want, depending on your problem. And these things are very good at coming up then with what it thinks are the essential features, and they pass it on to the next layer. So you finally get to the final layer and it puts it all together. And this has been the big breakthrough. I mean, it literally, it's an exponential jump in capabilities. Again, the problem with this is the classification, the features that the machines use are not the same ones we would use, and we don't quite understand what the machine's using. There's a lot of work on coming up with ways to figure that out. And here's an example of a convolutional neural network. Deep learning just means there's a lot of hidden units. The convolutional thing is you have these special transformations going on inside. So this is an example of classifying skin lesions. And it's just a picture. You give the picture, and the first part, not shown, but it's a typical ordinary neural network. The output is an ordinary neural network, but instead of 1 or 2 output nodes, there's 757. So 757 possible classifications for this piece of tissue, which that's a big problem. And inside are stacks of these convolutional networks, each one looking at a different feature and doing a different thing. And they work quite well, as we'll see. They can predict, they can classify tissue images like that with 92 or 93% accuracy. Well, here's another example of heart failure patients, and using machine learning, they could improve their prediction of outcomes. They can identify different phenotypes and detect patterns in the response to therapy. A year ago, a paper in JAMA talked about a machine learning technique that had better than 90% accuracy predicting metastatic disease from lymph node biopsies. And it was about equivalent, actually a little better than a group of trained pathologists. These are all board certified, highly trained experts. The machine could do it in seconds. It would take pathologists much longer to do it. And they did find that if a single pathologist, if you gave them all the time they needed, they could take all day on one set of slides, for example. They could approach the machine accuracy, but never quite beat it. So I think these are the kinds of tasks that will be useful in medicine, to refine and augment these traditional things done by human, which sometimes aren't the most exciting thing to do, to sit there and look at thousands of slides all day long. When a computer can go through them so quickly. Mammogram machines for years now have been putting out with the machine a computer learning algorithm that identifies areas of interest, and they would put a marker on the image and say to the radiologist, you might want to look at these. But it's still very crude in the science on that yet. Here's another example of predicting non-small cell lung cancer outcomes by looking at the pathology. When I tried to find examples, there were so many it was just overwhelming, so I tried to get a variety of them. This one I think is a very promising one. The patient comes in an emergency room with a head injury or something wrong neurologically. Well, the resident in the ER isn't a trained radiologist, most likely, but those MRI images can be run through a machine learning algorithm and detect a lot of things that they can detect it right away, almost instantly, once they take the image in the ER setting, and then that helps them in the triage and what to do with the patients. I think that's really interesting. Management can look at things like readmission rates, and they can take all of the factors they know, maybe for a large group of their patients, their diseases, their ages, their clinical parameters, their personal things, like did they have insurance or not, all of these different things, and they can look at predicting the 30-day readmission rate, and find the important things that they can possibly change to improve that. So why is all of this happening now? These machine learning tools have been around now since the early 60s and 70s. Well, there's been an exponential growth in computer hardware. The things I did back in the late 80s, early 90s that required a supercomputer, you can do on your desktop now. There's a thing called Moore's Law that says the complexity of a computer in terms of like numbers of transistors doubles every 2 years. So you can see that they started off very slow, and now it's going so fast that it's just almost straight up. And so things that were just unthinkable a few years ago now are quite practical. And then the recent advances in the software, the algorithm technology, the convolutional neural networks, that was a major breakthrough. And then the ability to take these trained networks and apply them to a totally different application and teach them very quickly what they need for the new application. That's the reason why all this is happening. Here's another example. This system detects 53 kinds of eye disease, again, as well as clinicians can do, if not better. In fact, here's a machine now that does that. So the convolutional neural network is built into this machine, and this is FDA approved, which that's really something, because FDA is very skeptical of these artificial intelligence results. They want to make sure that they're really correct before they approve it. But that's approved now. And here I think this is really cool. I do a lot of screening out into the rural communities. We have mobile units that go out and do mammograms and pap smears and PSAs and other things. If we had a trained nurse practitioner or physician assistant, they could take pictures, snapshots of skin lesions on their iPhone, transmit it back to headquarters. If you go through this network, and it would give them a prediction. Oh, I don't know if you can read it over here, but that's like a 73% probability of being a melanoma. And then it says it's got a little over 7% probability of being something else. So that's a great tool, I think. Not for replacing dermatologists, but for extending their reach out into the field and helping with triage of patients. Well, let me sum it up then. I don't think machines will ever replace doctors. Someone has to have the knowledge to train the machines to come up with these training data sets. The machine can't write prescriptions or take legal authority or give personal care to patients based on a lot of different factors. I mean, the machine might tell you, well, this person's probably got lung cancer, but maybe they have something else that's more critical at that time, and only a physician can see that. Even if there are dramatic breakthroughs in machine learning, I think they still need to be carefully evaluated before you put them out in the field. There's a classic example of Google Map. You know, they take satellite photos and then they have algorithms that would take those satellite photos and draw street maps from the satellite pictures. Well, they found one, they were training this one program, and it was doing a particularly lousy job of making the street maps, but this machine was trained to back generate the original photograph, the satellite photo, from its street maps, and that worked perfectly. So they didn't know what's going wrong. They knew there was a bad map, but the machine could map it back to the photo, and it was awful. Well, the machine was putting secret code in the maps to tell it the right answers, and it didn't really do the work on the algorithms. So that didn't mean the machine is malicious. It's just it very clever at finding a way of cheating. So you have to watch for this for things, and everything needs to be tested, I think, carefully before you put it into standard practice. So the way I see machine learning, it's a powerful tool for knowledge discovery, great for research and exploration, and I think more and more it will help augment the practice of medicine. So, any questions? Yes.
Although it's great advances, a small number of physicians are going to train the machine. The largest number will depend on the machine. What will be the consequences of not using our natural brain? Misuse, atrophy?
No, good question. No, I don't think our natural brains will ever become useless. They could just help you screen the data maybe faster, or help you choose where to focus your efforts faster, rather than spending a lot of time doing routine tasks that the machine can do well. So I think it would just make doctors smarter and give them more freedom to work on the more critical issues.
Well, still there's concern, because the kids now in school, if you tell the child, what is 5 plus 3?
Yeah.
He holds the phone and adds 5 plus 3. So there is misuse, atrophy in that brain.
Yeah.
Say it is faster and get it by the machine.
Well, I think that's a social issue that I can't tackle, but it's not a trivial. Yes, ma'am.
What do you think, just speculating, the advances with quantum computing and everything, do you think that we'll see that within the next 5-10 years working its way into medicine, or do you think that's going to be much further off? Since it's just starting now. So
You mean the quantum computing?
yeah, using quantum computing to do massive calculations. Do you think that will, in like next 20 years, do you think we'll see that in medicine, or do you think it's going to be way?
Probably.
way
You know,
far?
right now, quantum computing is not for everybody. It's very expensive and works on a very small scale. But if it does ever become practical, yeah, it'll just speed up the calculations. Plus, you could look at thousands of possible matches and outputs at the same time, you know, with the same algorithm. So it would just make things faster, I think. But I believe that's a good ways away. Well, thank you. You've been a good audience.